When you're diagnosing and managing blood cancers, the bone marrow pathology report is, without a doubt, one of the most critical documents you'll ever see. But what happens when those reports are messy, inconsistent, or just plain unclear? Well, today, we're diving into the evidence-based guidelines from the College of American Pathologists that are setting a whole new standard for clarity, one that's designed to directly improve patient care.
And I mean, just look at the difference here. It's night and day. On the left, you've got your traditional narrative report. It's a wall of text, right? And critical info, like a blast percentage, can get totally buried in there. But on the right, you have a synoptic report. Every key piece of data has its own line, laid out in this clean, variable result format. You can scan it instantly, nothing gets missed. And this isn't just about making things look pretty. It's about cutting down on errors and making clinical communication way, way better.
And the stakes, they couldn't be higher. The College of American Pathologists, or CAP, puts it very bluntly. When reports are all over the place, information gets lost, and that can lead directly to what they call suboptimal care. That means a real-world risk of a patient getting the wrong treatment or an inaccurate prognosis, all because a report was tough to read. The need for a change is obvious.
So, to really get to the heart of this, here's how we're going to break it down. We'll start with the problem itself, then introduce the synoptic solution. After that, we'll cover the core data every report needs, talk about integrating the full clinical picture, and finally, look at how to structure the report for just maximum clarity.
Okay, first up, let's really zero in on the problem, the high cost of inconsistency, and how it's a direct threat to managing patients effectively.
So, what's the fix? Well, it's an evidence-based framework from CAP. And this isn't just someone's good idea. It's a guideline that was rigorously developed to solve this exact problem of inconsistency. So what is synoptic reporting anyway? It's basically a structured format that presents every essential data point as a variable result pair. Think cellularity 80% or blasts 15%. This super simple structure makes sure that critical information is sent over consistently, briefly, and in a way that's pretty much impossible to miss.
And evidence behind this is it's overwhelming. This number right here, 11. That's how many key studies found that synoptic reporting is statistically provably better than narrative reports when it comes to completeness. In every single one of those studies, across a bunch of different cancer types, the structured format won, hands down.
So the benefits are really clear and compelling. A synoptic format boosts data accuracy and completeness. It makes sure a report from a lab in New York looks the same as one from California, which is huge for patient care. It gets the key info across quickly, and this is the big one. This whole approach is based on a serious, systematic review of the evidence.
All right, let's get into the nitty-gritty. What specific data has to be in every single report? We'll start with the core morphologic data, the stuff you're seeing under the microscope.
First up, the peripheral blood. The report absolutely must include key CBC parameters, absolute counts like the absolute neutrophil count, and of course, any relevant morphologic descriptors. These are often the very first clues to a bone marrow problem, so they're essential for getting the classification and prognosis right.
Next, the bone marrow aspirate. Now, the guideline lists a few key things here, but I want you to pay close attention to the one in bold, blast percentage. This isn't just a suggestion. It carries a strong recommendation. That means it's backed by the highest quality evidence. Getting this number right and reporting it clearly is absolutely non-negotiable for diagnosing conditions like AML and MDS.
And for the core biopsy, it's a similar story. We've got a list of essentials, including another strong recommendation, reporting on fibrosis. The degree of fibrosis is a major prognostic factor in myeloproliferative neoplasms, and it has to be clearly stated. The report also needs to cover cellularity, distribution patterns, and any assessment of lymphoid or plasma cells.
But, a modern diagnosis is so much more than just morphology. We have to integrate the full picture, and that means going way beyond the microscope to include all the ancillary tests and clinical information.
So, what is that crucial data we need beyond what we can see on the slide? A complete, accurate diagnosis really depends on pulling together multiple streams of information.
This table just gives you a few examples. For leukemias like ALL and AML, flow cytometry is key for detecting minimal residual disease. For AML and MDS, cytogenetics helps us define risk groups, and for CML, molecular testing for the BCR-ABL transcript is just the standard of care for monitoring treatment. These ancillary test results aren't optional. They're fundamental to the final diagnosis.
And that integration doesn't even stop with the ancillary tests.
The guideline also recommends that pathologists include key clinical and lab data, things like patient age or LDH levels, right in the report. Yeah, this requires some collaboration with the clinical team, but it's so important for making sure the diagnosis is made with the full clinical context in mind.
Okay, finally, let's talk about structure. How do we put all these pieces together to build a better, clearer, more effective report?
The guideline recommends a really simple, logical three-part flow. Step 1, the final diagnosis. Put the most important conclusion right at the top where no one can miss it. Step 2, the synoptic data section, with all those key morphologic and ancillary data points clearly listed out. And then Step 3, a narrative comment, but place it after the structured data. You can use it to explain complex findings or discuss a differential.
Now here's a huge real-world consideration that also carries a strong recommendation: electronic transmission. We've all seen it happen. Formatting like tables or bold text can get completely mangled or just disappear when a report gets sent to an electronic medical record. This means pathologists have to design reports that can survive that trip without losing clarity. Honestly, simplicity is usually your best bet.
At the end of the day, the goal is summed up perfectly by the guideline's own conclusion. This whole framework exists to improve the completeness of the report in a way that is clear, succinct, and, so importantly, consistent across all institutions. This is really how we standardize excellence. All right, let's do a quick recap of the key takeaways. 1. Synoptic reporting is an evidence-based standard, not just a nice idea. 2. It's proven to significantly improve data completeness and consistency. 3. The CAP framework tells you exactly what essential data you need for morphology, ancillary tests, and the clinical history. And 4. A clear structure with that diagnosis right up front is the absolute best way to communicate these complex findings. So I'll just leave you with this final thought. The next time you sit down to write or read a bone marrow report, think about this framework and ask yourself, how can a clearer, more consistent report change the outcome for my very next patient?